Finally, after all of that, the A&P, the electrophys, how to put leads on, how to read them, how to analyze, let's actually finally look at some rhythms, huh? Well, we're going to start from the top of the heart working down. So we're going to do sinus or atrial rhythms. So that's going to be ones coming from the sinus node, the right atrium, or the left atrium. I'm not really going to specify one or the other than sinus node beats. Just realize that atrial rhythms could come from any one of these locations. All right, mechanism of sinus rhythms. Well, quite simply put, the pacemaker is the sinus node. As promised, we're going to start with what's normal. Now, this diagram over here, get used to it because that's what I use to mark out the beginning of every single rhythm we pretty much go through in this class. And so here is your SA node or your sinus node, and that's where all these rhythms will start. Now, it regularly initiates impulses at a consistent rate, and they are conducted normally through the ventricles. Not much more complicated than that. So, what are the rules for sinus rhythms? Well, basically we divide those up on what the rate is. So if you have a rate less than 60, that's sinus bradycardia, also known as SB. If you have a rate between 60 and 100, well, that's going to be normal sinus rhythm, or just sinus rhythm. And if your rate is greater than 100, you've got sinus tach. Now, it's going to be regular. There are going to be no patterns at all. It's just going to be sinus rhythm. Now, your P waves are going to be absolutely perfect. They're going to be uniform, 1 P for every QRS. Your PRI will be perfect. It's going to be between 0.12 and 0.20. And of course, your QRS is going to be less than 0.12, but of course greater than 0.06. So the next couple of slides, I'm going to walk you through how to interpret these different rhythms. So sinus bradycardia. Well, let's start with our rate. I've got that and that, so I can do 1. So if I want to be really quick about it, now we are regular, so I can actually count the number of boxes if I would like to. And from here all the way to over here. So let's do the bounce method first. 3, 150, 175, 60, 50, right at about 40. So between 50 and 40 with the bounce. But let's go ahead and count those as well. So I've got 5, 10, 15, 20, 25, 30, 31, 32, 33, 34. So 1500 divided by 34 gives us a heart rate of 44 beats per minute. Again, all of this agrees it's bradycardic, so we know it's slow. Now in terms of regularity, absolutely perfect. Is there a pattern? Nope. And there's no ectopics. On to our P waves, which are pretty easy to find. They are all upright and uniform. And they appear to be pretty darn regular. If I wanted to double check this, I could mark from here to here. Measure that out, comes out to about 34 as well, and repeat down the line, and that's how you confirm that they're correctly spaced out. So we will say they are regular. I have 1 P for every QRS. As for our PRIs, what do we got going on here? Well, this P wave starts right there, and then my QRS ends about there. So that's 1, 2, 3, 4. So 4 small boxes. And since we've agreed that essentially each beat is identical to the other, 1 can stand in to represent the rest, and so I've got 0.16, which is normal, correct? Last but not least, our QRSs. They are indeed uniform. We have QRS pattern, and if I measure these out, well, in fact, I'll just take advantage of what I already have marked and say that that's about 2 apart. And that is normal as well. And I looked around, and of course there were no ectopics either. So I have sinus bradycardia, just that simple. Normal, normal, bradycardic. Okay, so next in line, we'll do the same as we did before. Are we regular? Yes. So let's go ahead and try our bounce method again, and we'll go 3, 150, 175. So we're between 100 and 75, but we're closer to 75. But because it's regular, we can actually count, and so we'll say that that is 5, 10, 15, 16, 17, 18, 19. So 1500 divided by 19 will give us 79. Again, normal. Back to regularity. It is regular. We have no pattern and no ectopics. What do we have for our P waves? Now, I'll go ahead and mark those out for you real quick, etc. And they all appear to be upright and uniform. Are they regular? Well, they certainly appear spaced out regular, but of course we can do the mark here, measure these out. Around 19, use a pair of calipers, measure out the rest of the way, but they are regular. And I have one, that looked awful, 1 P for every QRS. That's about all I can hope for there. Let's go ahead and measure out a PRI, and this will actually be one of the easiest to measure because it falls just on this side of the line. And then I'll measure this one here. Oh. So I've got 1, 2, 3, 4. I can measure another one and do this one here, and then this one here. 1, 2, 3. We'll go 4-ish on that as well. So 4 times 0.04 equals 0.16, which is normal as well. And finally our QRS. Just looking across the screen, you can see that the QRSs are uniform. And they have the QRS pattern. I have a width of right at 1, 2. 2 times 0.04 gives us 0.08. And that is also normal. And of course you can cross-check any of these numbers with the other ones just to make certain that everything's uniform, but normal, 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 that is normal sinus rhythm, as perfect as it gets. Now I should make note, if there's any kind of problems with this, an ectopic beat or anything that throws it off from being this perfect, it is no longer sinus rhythm, and it is no longer normal sinus rhythm, you just call it sinus rhythm with PACs or whatever the case may be. All right, and on down the line, just like before. And yes, I'm going to be doing this for pretty much every strip. So what's my rate? Well, it's a 6-second strip. I've got 14 beats, so 14 times 10 equals 140, and so that is tachycardic. Are we regular? And the answer is yes. So let's try our bounce method, and actually, this one starts right on a big solid line. So let's go 300, 151. So we're between 150 and 100 beats per minute, but probably closer to 150. Overall, if we're actually going to count these, that's 5, 10, and then 11. So 1500 divided by 11 gives us 136 beats per minute, which ain't bad. Again, tachycardic. So we are regular. Is there any pattern? And the answer is no. There are no ectopics. What can we learn about our P waves? Well, they're a little more tricky to see this time because they're scrunched so close to the QRS, but again, find the QRS, look for your P wave in front of it. So if this is my QRS, that's my P wave, and it looks great. It's rounded, it's got the little PRI notch right in front of it, and so that would make this the T wave behind it, and so I can go backwards and forwards now labeling everything. So my P waves all appear to be upright and uniform. Are they regular? Well, this one starts here, this one starts here, and it's 5, 10, 11, and those are 11 apart. So 11 small boxes. So then I could go through and count more if I wanted to really confirm things. And it's important to note, I measured the P to P over here on the left, and it matches the R to R way over here on the right, meaning that these are completely interchangeable. So what is my PRI? Well, I like that this one starts on a solid. It ends right about here. And that is 4. Lastly, my QRS. Are they all uniform? Absolutely. They have the QRS pattern to them. And how wide are they? Well, it's a pretty good one. This starts on a solid line and ends right about here. So that one's actually about 2.5. Which again is normal. So I have a normal QRS, I have a normal PRI, I have normal P waves, it's regular, just a little bit tachycardic. That's sinus tach. So even though there's not much to say on this slide, I'm doing it to establish a pattern from what you can expect, which is talk about the mechanism, talk about the rules, give you an example of how to actually figure it out, and then go through and explain why that certain rhythm is important. And in the case of normal sinus rhythm, the reason it's important is because that's what's normal. That's what it's supposed to do. It doesn't produce any symptoms because it's normal. So that's the shortest way I can say that, honestly. Now, sinus bradycardia, on the other hand, does give us, a few trips here and there. Why is sinus bradycardia important? Well, if it comes out of nowhere, if it's new, it can be a prequel to other problems like blocks or even asystole in the worst case scenario. And what does it produce when it's going badly? Well, you'll have a slow, regular pulse, but if that pulse is too slow, let's say way down in the 30s or worse, that can actually cause signs and symptoms of decreased cardiac output, also known as CO. And we'll talk about that in just a little bit. What can cause sinus bradycardia? Well, well-trained athletes, Olympians, frequently have heart rates in the 30s because they're so dang healthy. I'm sure the CrossFit kids have the same problem, so to speak. But problems that can actually cause it would be an MI, myocardial infarction, vagal stimulation. We talked about that a little earlier with the carotid body stimulation and how syncopal episodes can come from that. Or increased intracranial pressure. That's a late sign of high ICP that we watch out for sometimes. One other item that's important for sinus bradycardia is not only the new onset, which I'd mentioned, it's also when it's not responsive to stimulation. So if your patient's bradycardic, you go in there and you're doing a sternal rub and they stand up and they look at you and they're talking wide awake and their heart rate doesn't budge from a bradycardic number, that's a sign that it's inappropriate at the time. So finally, sinus tach. Why is this one important? Well, normally sinus tach's not a problem. It's a natural response to a lot of different stimuli. But in the case of acute myocardial infarction or a heart attack, that can actually make the heart attack worse. If you think back to what we were talking about with the O2 needs of the heart, that diastole is super important. And when you're tachycardic, you have less diastole. So in an MI, when you're not getting enough blood flow already, speeding up your heart increases how much oxygen the heart uses and cuts down on the amount of time that the heart has to replenish itself. So that's one area where sinus tach is actually pretty decent. Clinically, what do you see? You see a rapid regular pulse. If it goes on for too long, they might become symptomatic. And by prolonged, I mean, hours to days, depending on how healthy the individual is. It can cause palpitations or dyspnea sometimes. What triggers it? Well, when you have hypovolemia, so when you're dehydrated, or relative hypovolemia, like in severe sepsis or septic shock, any kind of shock for that matter. If you're in heart failure, people who have late-stage heart failure are frequently tachycardic because that heart's having a tough time doing its job. Fever's a great one. I've had plenty of patients that they're tachycardic when they're febrile. You break their fever, tachycardia goes away. Activity does it. Back to those CrossFit kids and Olympians that are working out. Pain does it. I'm sure we've all seen this, and the anxiety that goes with that. All of these items are stress, and that just brings up your heart rate. So, last thing I want to say is when we become symptomatic, that's another way of saying decreased cardiac output. So I've mentioned it a few times. I need to finally sit down and explain what cardiac output actually is. So when you have decreased cardiac output, it's a sign that you're not getting enough blood flow to the areas of the body that you need to. And so your body responds in a fairly consistent manner. And you can have any combo of these. It can be as generic as anxiety, or just chest pain, shortness of breath. Maybe they're sweating a little bit. Hypotension's a very obvious one. That's why we get vital signs on patients as soon as we can. Cool, clammy skin can come with that. Cyanosis, because they're not actually moving enough blood through their lungs potentially. And then this one here is decreased LOC, which I think is probably the most important one, in my opinion, because you have to lay eyes on your patient. One of the first signs that someone's got a low cardiac output may be that they're less responsive, they're more sluggish, difficult to rouse. So you gotta check the patient, check the vital signs, and slap a telly on them if you can, just to see if the heart rate or the heart rhythm has anything to do with that. But when I talk about decreased cardiac output, it's any one of these items happening together. Your patient started the shift in rhythm A, later alarm sound, and you see rhythm B. What action would be most appropriate? So we've started our shift in, well, we'll have to look. They start off with a tachycardic, and now they're Brady. Severe. Their heart rate of like 30. So this is a significant drop in heart rate. That alone tells you how big of a change this is and how panicked you might be. First off, we'll ask, does this look like it's a false alarm? No. Is it non-emergent and that the CNA can evaluate the patient? Again, I would say no. At this point, who needs to go look at this patient? Do we call an RRT and have the ICU nurse take a look at them, or do we just notify the primary nurse and have them take a look? Well, this is not non-emergent. That's a very, very, very low heart rate. I honestly would recommend probably calling the RRT at that point and having the ICU staff be the ones that go take a look, because that right there might lead to something much worse. If you chose to contact the primary nurse first and then wait to see what they did, that could cause some delays that would potentially harm the patient in the long term. So I would say for a change like this from extreme tachy to extreme bradycardia, this is emergent, call an RRT and have the experts get in there. The telemetry tech notifies you your patient has been in atrial flutter with rates of about 130s, but is now in sinus bradycardia with rates in the 30s to 40s. What first action would be most appropriate? And the question becomes, is this an emergent situation or non-emergent? Your patient's heart rate has just dropped by 100 beats per minute. That absolutely makes this a critical type scenario. And so if you receive a call letting you know that this has happened to your patient, you're not going to have a CNA take a look. You're not going to waste time notifying the attending first and then going to look at your patient. No, you are going to be the one who goes and evaluates the patient as quickly as possible, and then call an RRT if the patient is symptomatic. Now, it may very well happen that someone else can call an RRT for you simultaneously, but that's not your job. You, as the nurse being told that your patient's heart rate's dropped that much, need to go evaluate that patient as soon as possible, because we don't want to delay someone laying eyes on them. Okay, and now for probably one of the most common premature beats that you'll come across, and it is the PAC, premature atrial contraction. The idea is this: you've got an ectopic pacemaker, and it's an irritable focus within the atrium, and literally I mean anywhere. Now I just have a star here, but in all honesty, it can be here, it can be here. Even the sinus node could do it if they wanted to and just fire off early for some reason. So left, right, front, back, PACs can happen from just about anywhere. But what's important about a PAC is that it's a single ectopic beat. It's all by itself. It's not part of any larger organized rhythm. And then of course conduction is normal through the ventricles. So what are the rules for a PAC? Well, I want to start out by saying these are the rules for just the single PAC. It's not for the entire rhythm, it's just the PAC itself. So your rate really just depends on underlying rhythm. Regularity, well, that patient's rhythm is going to become irregular because you've added an ectopic beat that's interrupted that. Now it may create a pattern, that can happen sometimes, it just depends on how many of these you wind up have come through. For the PAC itself, the P wave is actually really important because that early beat may differ from the sinus P waves. It can be flattened, it can be notched, it could even be lost in the preceding T wave. All important things to keep track of. As for the PAC itself, it should have a PRI between 12 and 20. Shouldn't really be any longer than that, but it can be. And then last but not least, your QRS should be perfectly normal for a PAC. It really shouldn't look any different than a normal beat that was right before it. All right, so let's take a look at a rhythm that has a PAC within it. We'll do our usual markings. And I've got one. And as you're looking at this, you can probably already see which beat is out of place. And it's beat number 4. This one is earlier than it should be. There's a gap here, and that's because this one is sooner than it should be, because this space is a lot tighter, correct? Just like the premature beats we discussed earlier. So let's walk through this. We know it's irregular. So what's our rate? Well, it's irregular, so let's just go ahead and call it 8 times 10. And that's got a rate of 80. And that's about all we need for this. And we know that that's normal. Now, other than being irregular, we do have an ectopic. That's early. But we don't have a pattern. It's just one. What can we say about our P waves? Well, let's look at our normal beats first. We should always ignore the ectopic beat and come back to it afterwards if we can. And so that's a normal, that's a normal, that one, even that one, and so on. And it looks like we are upright and uniform. I'm actually doing N for normal. And are those regular? Well, five, 10, 15, 16, 17, 18. About 18 beats between them. If I do the next one, 5, 10, 15, 16, 17, 18, 19-ish. So just about even, not quite perfect. So we've got that, so they're fairly regular. I've got 1 P for every QRS. Now, what's the PRI for our normal rhythms? Well, let's see here. Well, we'll say that this was the start of that P wave, and we'll say that this was about the end. 1, 2, 3, 4. So we'll say 4. So our normal so 16, and that's normal. And so we'll take a look at our QRSs next, and across our QRSs for all of our regular beats, we will see that those are uniform. They have the QRS pattern. And then our width, which we'll go ahead and measure this one, right at about 2. And so that's normal. Now let's go back and take a look at our ectopic beat, and we'll just call this beat E. And so beat number, or beat letter E, now that P wave is upright, and my PRI, 1, 2, 3, 4, it's right at about 4. Now that P wave actually matches all of the other P waves, so I will say it's upright and it's uniform. It matches the other ones. It doesn't have any regularity because it stands by itself, but it has 1 P for each QRS, and so that's good. What's the PRI for that one? Well, we actually measured it, and it comes out to 4 times 0.04. And so that is also normal. Finally, we'll talk about the QRS on that, and just by looking at it, you can tell it matches exactly with everything else. So we know that that's uniform because the conduction happened appropriately. It's the QRS pattern. And in fact, if we measure it out, it is right at 2 as well. So you have sinus rhythm with PAC. And so you see how we named it sinus rhythm, because that underlying rhythm matches all the criteria we need for a normal sinus rhythm. We just have that extra PAC in there. And so that PAC makes it not normal. So at that point, we call it sinus rhythm with PAC. So why are PACs important? Why are we bothering? Well, ultimately, they're usually pretty benign. A PAC by itself isn't going to ruin anyone's day. In fact, by themselves, they rarely cause symptoms. What is important, though, is that they may be a sign of something else underlying some other problem, because what causes them to happen can be hypoxia, someone with CHF where their heart has been stretched out or getting worse, someone having ischemia, which is not unlike hypoxia, digitoxicity, so if someone's on that medication, it could be a sign that their either digoxin level is out of whack or maybe their potassium level is. Excessive alcohol consumption can always do it too. One of the really important triggers to talk about is caffeine, and the fact that they've actually done some studies, and a study of actually 1,300 patients, so no small study, found that heavy caffeine consumption versus non-caffeine consumption really didn't change anything. So saying that caffeine causes this stuff to happen is really not necessarily that accurate anymore. So kind of keep that in mind next time you're pounding your 4th or 5th cup of coffee for the day, that may not be what's causing your PACs. Other things I do want to mention, though, is the risk is that if a patient's having PACs, those can eventually get out of hand and they can trigger a atrial tachycardia, or worse. And there's lots of different versions of that, but I just want to let you know that PACs by themselves aren't a problem, but if they don't go away, it could become something more. All right, so let's talk about a flutter, atrial flutter. This arrhythmia arises from a single irritable focus within the heart, atria specifically, that fires off rapidly and repeatedly, and it's firing so fast that not every single impulse is actually able to make its way through the AV node. In fact, there's the absolute refractory period, that prevents that AV node from responding to every single one of these beats that comes through, and so it leads to an intermittent block or intermittent conduction. The ones that do go through conduct normally. And so what really makes a flutter kind of cool is the fact that it just cycles over and over and over again as quickly as it can, which is what gives it its characteristic sawtooth appearance. The rules for atrial flutter include 2 parts. You actually have to look at this at the atria and the ventricular rate separately. And so that atrial rate is going to be in the 250 to 350 range because those P waves keep happening at such a rapid rate. It's just one after the other. Whereas your ventricular rate, depending on how often it's being blocked, you're going to have QRSs that pop up in different locations, and so you'll have a separate rate for those. The atrial rhythm is actually going to be very regular, but the ventricular rhythm is usually regular, but in the cases where the block is variable, that can create irregularities. Your P wave is going to be super unique. It's going to have that characteristic sawtooth pattern. You won't be able to get a PRI because it's just one P wave after another. But your QRS should be normal. So let's take a look at another one. I've got those marked out. So we have a 6-second strip, and it looks perfectly regular. There's no pattern. And no ectopics. But I will say that it looks like there's 3 Ps per QRS. And we'll come back to that just like we did before. Overall, the rate, we can do the simple way to just awesome. Or we can count boxes, and so we'll just count between 4 and 5. Where I've got 5, 10, 11, 12, 13, 14, 15 small boxes. It's normal. But again, this is the ventricle. For the atria, I need to measure differently. And so we'll just go from the start of any of these P waves, which is right here, to the end about here. And so that's 1, 2, 3, 4, 5. 1500 divided by 5 gives you 300 beats per minute for your atrial rhythm, which fits in with the sawtooth appearance that all of this has. So again, how do I come up with 3 to 1? Well, we'll just start here, and we'll label this where it looks like the T wave. I know better. It's actually the P wave combined with the T wave, if not overwriting it. And so you have A, B, and the start of C is right here. And so we'll just kind of arch these out. And then we start over again. And you'll see how C is partially canceled out. So in the previous example, the QRS had completely obliterated that fourth P wave that we were looking for. In this case, it only partially obscures the third one. But we definitely have figured out that we have 3 P's per QRS. We can't measure a PRI. As for my QRSs, they are uniform, and they have the QRS pattern, particularly number 7. You can really see that. And we'll just go ahead and mark this 2.5 or so. 0.10, which again is normal. So with the sawtooth pattern, we figured out the 3 to 1 block. All we have to say is that this is a atrial flutter with 3, 2, 1 block. Alright, so here we have another one, and this is a full 6-second long strip. It is a little bit irregular. You can see how there's a big break through here, and then it's kind of snug through here. So we'll just count these out. 1, 2, 3, 4, and 5. And of course your atrial is going to be from here to about here, and that's about 5.5. Turn 73, something in that zone. So this is Brady. We're going to say this is irregular. There's no pattern other than there's the P waves are greater than the QRSs, and there's no ectopics. So let's take a look at these P waves. They're definitely sawtooth, and they're regular. So let's figure out how many we have. We'll start the same way we always have. We'll just label this one A. And it would not be surprising if we followed our same pattern that there's an H hiding in there. And there's an E. It actually just stops at F. There's no additional one hiding in there. And F again. So This is actually a really unique one because we wind up with a 8-to-1 block. We have a 1, 2, 5-to-1 block and 6-to-1 block. So quite variable indeed. No PRIs. QRSs are uniform. A little bit difficult to measure what the true PRI, or sorry, the true QRS width is on this one because so many of them are integrated. But I think number 4 will be a pretty easy one to measure. And we can just assume that it ends right around here because it's sharing part of that P wave. We'll say 2.5. It's just the R wave pattern. Which is normal. And so yeah, you have atrial flutter with variable block. As a side note, this patient should have pacer pads on their chest, because if this gets any slower, it could get really bad. I'm just going to point out something real quick here for you. And we're going to measure these out ever so swiftly. 5, 10, 15, 20, 25, 30, 35, 6, 9, 10, 11, 12, 42 boxes. Gives us a rate of 35.7. So if he or she continues up this 8-to-1 block, they're going to have a heart rate in the low 30s. And that's someone who may wind up symptomatic and really needs to be ready to be treated. So kind of get ready to dust off any kind of ACLS in case this patient becomes symptomatic, because we want to help them out as best we can. Probably start drips too, dopamine, things of that nature. So why is A flutter important? Why are we bothering? Well, the big reasons that we get excited about A flutter is, first, you lose that atrial kick, which means you lose your cardiac output, or it drops significantly, I should say, of about 20 to 30% of your blood pressure, and everything that you can muster just falls off as soon as you lose that atrial kick. So that's one really big important thing. And the second big thing is your emboli risk, your chances of developing a clot in your heart and then kicking it out into somewhere else. So to kind of go through these both, the drop in cardiac output can quickly lead to a lower cardiac output, particularly with a rapid ventricular rate. It's actually kind of funny. The faster the heart rate goes, the odds of you having a drop in cardiac output are a little bit higher, which will only compound other problems, like if you already are having a heart attack, if you already have heart failure, or if you already have emboli in there, that can actually cause them to be kicked out or dislodged and moved to the rest of the body. Who's most likely to wind up in A flutter? Well, people who've had atrial stretch, and so that's pulmonary patients. They're most likely to have this. People on antiarrhythmics, actually the drugs you take to go from AFib to try and fix that can sometimes cause you to be in A flutter, particularly amiodarone. So it's not uncommon to see that combination. And cardiac surgery, anytime you, make the heart angry. And yes, we're drawing in green because the Hulk's involved. No, not really. But still, cardiac surgery irritates the heart. That's one of those triggers for sure. So keep in mind, emboli risk, because those can go to the lungs or to the brain, and drop in cardiac output, which then just decreases all of your faculties at that point. Your patient started the shift with rhythm A. Later on, the alarm sounds and you see rhythm B. What action would be most appropriate? And so for monitor techs, what are we going to do? Well, is this appear to be a false alarm? Nope, not at all. Is this an emergent change? Well, you really have to figure out what is your rhythm. So I'll give you a second to look at it, pause if you want, but I'll go ahead and start saying it now. We're in A flutter, and it's a little bit of a fast rate. And here we go to sinus Brady with PAC. And we've got 1, 2, 3, 4, 5, so we got a rate of about 50. So again, is this emergent or non-emergent? Well, it's non-emergent because they've actually gone to a better rhythm, so we don't have to worry about either of those. And now we ask the question, do we have the CNA look at this patient, or do we have the primary nurse be the one who gets notified and have them look at the patient? And that's the truth. This is not for a CNA to deal with. We need to notify the nurse themselves so that they can do the rest of their job. The telemetry tech notifies you your patient has converted from atrial flutter with rates in the hundreds to sinus bradycardia. What first action would be most appropriate? So the question is, has your patient gotten worse or have they gotten better? Sinus bradycardia is a more natural rhythm, and so at that point they've gotten better. So is this an emergency that they've improved? No, it's not. So you don't have to worry about doing an RRT or notifying the attending immediately to have them come look. Now, while this is non-emergent, do you want the CNA to go check on your patient? I don't think so. You as the nurse, it's your responsibility. So do you notify the attending about the rhythm change right away? No, you should actually go evaluate the patient first, then notify the attending, because you want to get a fresh set of vital signs and all that good stuff. Okay, let's talk about atrial fibrillation. This one's really neat because you have ectopic pacemakers. It's actually a multitude. The best example I can give you would be like raindrops on a puddle. It's just pure chaos, right? Those drops are hitting multiple at the same time in multiple areas, creating ripples that collide with the other ripples nearby, and it just makes a whole mess. And so that's the idea, is that on the left side of the heart and the right side of the heart, there's just a mess of these going off simultaneously. There's no organization whatsoever. And because of these impulses firing, it creates fibrillatory muscle movements. It's bag of worms is another way people like to describe that. And that's actually something that we pick up on the EKG as F waves. Not terribly unlike your artifact from muscle shivering, except way more sublime. It's really tiny, mostly impossible to see in a lot of occasions, and we'll go through some examples of that. The next important thing, and what makes a fib similar to a flutter, is that AV node blocks some of these impulses from getting through. And the best way I can describe that is, you know, those buildings and those fancy hotels that still have the revolving door. Well, if you've ever seen a crowd of people try to go through one of those, that's a lot like how this works. Sometimes 3 people will cram in and they'll all get through, and then just one person, and then maybe 2 people, and then it may go a whole rotation with no one going out at all, and then there'll be another 2 people. It's just absolutely regularly irregular in terms of what your conducted impulses do, the number. Once they get through the AV node, they conduct normally and they look just fine. So, rules for atrial fibrillation. Well, we, like many other rhythms, use different names based on whatever rate it's traveling at. And so if you're going less than 60 beats per minute, that is AFib with slow ventricular response, or SVR. So there's no such thing as bradycardic AFib. You actually call it atrial fibrillation with SVR. Now, if you happen to be in the rate of 60 to 100, that's simply controlled AFib, meaning that heart rate has been controlled to the point where it's within a normal range. Anytime it gets above 100 beats per minute, that's what we call AFib with rapid ventricular response, RVR. And it's important to make those distinctions because you don't want to call it tachycardic AFib. Oh no, it's AFib with RVR, AFib with SVR, meaning slow, fast. Irregularity from both a ventricular and atrial standpoint is just grossly irregular. And as I had mentioned before, regularly irregular. No discernible P waves. You shouldn't be able to see any. If anything pops up, it's going to be these fibrillatory or F waves. If you don't have P waves, you can't measure a PRI, but your QRSs should all look just fine. Apologies, this is another short strip. Didn't quite get what I wanted from the internet, but we'll still be able to do the job because this is so grossly irregular. So we can go ahead and mark that out right off the bat. I went through myself, measured every single R to R, came up with the average, and so we're sitting right around 120 beats per minute. It's actually faster than it looks. So we are irregular. We don't have any ectopic beats that we can really tell. There's a few spots that look like maybe that's a P wave or maybe that one is, but nothing really consistent that we could rely upon. So we're going to say no ectopic. There's no pattern. We really don't have P waves, but we do have F waves. So no P equals no PRI. And then our QRSs. And so they're not quite uniform. I'm going to go ahead and number these off now. And so within these, there's a few of them that look different. But overall, we're going to do this. So we're going to say that they're not uniform. But they are all fairly similar, right? They all have some form of the RS pattern, by and large. And when we measure them out, let's go ahead and look at a few different ones. So if we measure this one here, and let's say he ends here, that's 1, 2. So this one's about 2. And we'll measure another one that looks really different. Oh, this one looks really different. Number 3. And that one's also just right at 2. We can measure one of the other ones here to here. That one's 1.5. That one's 2. So they're all just about the same size, anywhere from 1.5 to 2 small boxes, which means so regardless, they're all pretty much normal, even though they look a little bit different. So at the end of the day, you can just say that because this is tachycardic, you have F waves, and you've got essentially normal QRSs, that you've got atrial fibrillation with RVR. rapid ventricular response. So what's so important about AFib? Why are we looking at this? Well, for number one, it is common. We see it all the time. In fact, you are more likely to go into AFib the longer you live. There's some specific formulas for that, but it kind of boils down to the idea that by the time you're 90 years old, you're almost 100% likely to have AFib by that point in your life. But more importantly, it's very similar to a flutter in that you get that rapid rate plus the fibrillation of your atria, and that causes loss of your atrial kick, which causes decrease in cardiac output by 20 to 30%. And additionally, there's that extra high risk of emboli, even worse than with a flutter. So with the decreased cardiac output, of course, you can get these signs and symptoms of that. And with your emboli risk, which is over here in the outcomes section, you can have it to your brain, which is, of course, stroke. That's why when someone presents with the stroke, one of the first workups we do is getting a 12 lead to see if they have AFib or not. And, of course, pulmonary embolisms in your lung. Now, if you're in AFib, you've basically bought yourself some treatment, and that's going to be anticoagulants. And maybe even some antithrombotics to help reduce the risk of you making emboli that may cause trouble down the road. Other treatments include a cardioversion to try and kick you out of that rhythm if medications are unsuccessful. What triggers it? Well, atrial stretch. You almost liken it to when you have wires, that if you stretch out wires, they start sparking and arcing across one another. And AFib kind of works that way. You stretch out the heart, those are electrical little muscle fibers, and they can start making sparks of their own. Hyperthyroid, because that just tweaks your heart a little bit, just makes it more likely to be reactive. Cardiac surgery, go poking around. Of course, it's likely to be irritable. And of course, digoxin can easily throw that off as well. Last thing I want to touch on is this section here. You are definitely going to have an irregular pulse. It may be fast or slow, just depends. But one of the things we frequently see on our monitors is a patient's in AFib, it's really irregular and it's running fast. And so their heart rate, which is your telemetry, reads like 110. But then your pulse, I'm going to change colors for this, your pulse reads 95. And so the question becomes, which is correct? What's going on? If I record my vitals and say their heart rate's 110, but their pulse is 95, am I lying? Am I incorrect? What did I do? How did I screw up? Well, the reality is, when the heart rate is going really fast, some of those heart rate impulses don't actually move any blood. And so what happens is you wind up with a pulse deficit. So it's always important that just because your patient has a high heart rate, don't assume their pulse matches. Go check it manually, get your hand on their wrist, do those kinds of things. But that's what I'm talking about when we talk about heart rate versus pulse. We'll touch on that with a few other things later on in the presentation. Last but not least, one of the number one things that you'll present with your first onset of AFib is going to be syncope. That's right. You're most likely to present with episodes of passing out as one of your reasons for getting medical care. Decreased cardiac output, CO, may present as which of the following? Will it show up as chest pain? It absolutely can, because that heart may not be getting the perfusion it needs. Hypotension? Absolutely, because if the heart's not putting out enough blood pressure, you might, or not putting out enough force, you might have low blood pressure. Decreased level of consciousness? Absolutely, because you're not getting enough blood flow to your brain. Shortness of breath? Definitely, because it feels like you can't catch your breath, either because blood backing up or because it's not moving well enough throughout your body. And anxiety, you don't feel good. So these folks might even just show up super anxious, and then you figure out all this other stuff. So yeah, essentially all of these are items that may be present with decreased cardiac output. Your patient started the shift with rhythm A, and later the alarm sounds and you see rhythm B. And the question is, what would be the most appropriate action with this rhythm change? First thing you need to do is figure out what two rhythms you have. Take a second, figure it out yourself. Go ahead and pause, but I'll give you the answer right here. Your top one is sinus rhythm with PAC, and it turns into AFib with RVR, rapid ventricular response. You've got a heart rate greater than 100. And so now, is this emergent? Is it non-emergent? Well, it's a rhythm change, not for the better, so it's definitely not a false alarm. That's not artifact or anything, because you can see how irregular it winds up being. Notifying the CNA of the rhythm change isn't the right approach either. Is this a lethal arrhythmia or something that's worth turning into an RRT over and have the ICU nurse go evaluate the patient right away? No, it's not that dangerous, but it isn't good. And so now you have to decide, is it non-emergent? Well, I'll just let that primary nurse know when I have the chance. Or is it emergent, that I'm going to immediately contact that primary nurse and escalate if I can't get a hold of them? And honestly, I think that's the right answer. It's a thing that when your patient goes into AFib, it's never for a good reason, and you want to be able to make sure that the nurse is aware of it so that they can do whatever interventions may be necessary, whether that's anticoagulation or whatever. So please keep that in mind, and there you go. The telemetry tech notifies you your patient has gone from sinus rhythm to atrial fibrillation with rates of 115 to 120s. What first action would be most appropriate? Now, is this non-emergent and you can just have your CNA evaluate the patient? No, this is a rhythm change. It needs to be a nurse who's involved. So does the primary nurse evaluate the patient and then notify the attending? That's completely appropriate. Do you just call the attending provider right away and don't even look at the patient? Of course not. So C, off the table. Is change from sinus rhythm to atrial fibrillation emergent? Do we need to call an RRT? Do we notify the attending provider immediately to come evaluate the patient? No, absolutely not. So neither one of those are correct either. It really comes back down to the primary nurse needs to evaluate the patient and then notify the attending. Supraventricular tachycardia. What the heck is it? Well, essentially the idea is it is a very fast rhythm that is being generated by either the atria or the AV node. It's everything that is above the ventricles. That really doesn't tell you a lot though, does it? It just says that, hey, it's above this area, and that's the most I can say. It's not an accurate description, and the reason we use this is because P waves usually aren't visible. That's the big part that helps lead us to this. To try and illustrate what I'm getting at, I'll ask you this question. What has 4 legs, is furry, and barks? Well, of course, it's a dog, right? It's not too hard of a question to ask. Most everyone's seen a dog. They have a basic idea of what they look like. However, a lot of different images can pop in your head what a dog means to you. Now, if I was to say Chihuahua or Saint Bernard, you'd immediately be able to picture 2 very different animals in your brain. You know, big one, small one, a lot of fur, practically no fur at all, things like that. And if I was to say black lab versus chocolate lab, essentially the same dog, except for there's a color variation between them. And that's the idea of any of the naming we do with rhythms, is to say the most exact one that we can, so then you can get a better picture in your head of what you're up against. In the case of SVT, supraventricular tachycardia, it's the best answer that we can get. We can hear a dog barking, so we know it's a dog, but to be able to tell more from it, it's very difficult. So what this comes down to is the two most important things, which is one, treat the patient. 2, slow it down. When these rhythms are going on, you really need to take care of the patient first. If they're having blood pressure issues or whatever, fix that, and then work on figuring out what kind of rhythm you're dealing with. If they're just falling apart, maybe fixing the rhythm is what you need to do. That's where ACLS comes in. And we have different things to deal with it in that pathway. So, moving on. So, supraventricular tachycardia rules, SVT. It's gonna be fast. One of the faster rates you may encounter. But it will be quite regular. That's one of its hallmarks, is that it's going so fast that it has no choice but to be regular. You're not going to be able to see any P waves because they're likely hidden in the preceding T wave in most cases. So, because you don't really have a P wave, you can't have a PRI. And lastly, your QRS pretty much always should be less than 12 seconds. It should less than 0.12 seconds. It should be narrow. Okay, here we go. So we have a 6-second strip. I'm going to go ahead and mark these out. A lot more tedious with these faster rhythms, isn't it? But thankfully you have a fast forward function on YouTube, so you can just jump through that part. Anyway, 6 seconds long, 22 beats on this, so 22 times 10 equals a rate of 220. We are very regular. We don't have a pattern. We don't have any ectopics. Because we're such a fast rhythm, we can actually measure these out, and thankfully number 3 is right on a solid line, and we'll mark you here, and so across is 7. That gives us 214. Very fast indeed. So let's take a look at our P waves. Can't see a darn one of them. If they do exist, they are mixed with the T waves. And because all of them are uniform, there's no way to tell how much of that is T wave, how much of it is P wave. So they just don't exist for all we know. And so because of that, there is no PRI. Let's go ahead and say no P wave here. So that just leaves us with the QRS to take a look at, and those are uniform. And they have RS pattern to them. It is definitely narrow. And how narrow is it? Well, if we look at number 8, it actually starts on a solid line. Sorry, I drew that at a bit of an angle. And then it ends right about here, because that's your J point, right where the S wave ends and the ST segment begins. And so that right there is 1.5. Equals 0.06, which is normal. So we have very tachy, we have regular, no P waves that we can see. We have a normal QRS. SVT is the best we can do. I can't prove that this is, is it sinus tach? Is it a flutter? There's no way for me to tell the difference between them because I can't see the P waves. So I can't use, So I can't use either one of these. I just have to stick with SVT. It's my best worst answer. What I will say is this though, and I'll actually write this in red because it's that important. I cannot emphasize this enough. You have to check that patient first. That's what makes the biggest difference in what you're going to be able to accomplish. Because if they are unconscious or unstable in any way, get a set of vital signs. That determines your next steps. If they don't notice that anything's going on, then we still get our vital signs, check on the patient, and call the doctor. Why is SVT important? Well, the biggest part of it is that the rapid heart rate can really drop that patient's cardiac output. That's the biggest concern that we have, or the most pressing concern that we have when someone goes into SVT. In fact, we divvy them up into stable and unstable. Now, if they're stable, that's good. It means they're maybe just a little lightheaded, but otherwise they're in pretty good shape. And we can work through it. We can diagnose the rhythm and we can treat it with meds. Nothing terribly emergent. However, if they're unstable, and so those are those signs and symptoms of decreased cardiac output. So chest pain, maybe they're short of breath, sweating, hypoxia, hypotension. If they have any of those types of things going on, we're actually going to follow ACLS and do what they would do for narrow complex tachycardias with symptoms. Current recommendations at this time are doing things like vagal maneuvers, you can also try adenosine. And that drug dramatically slows heart rate. And if that doesn't work, or if you're running out of time because they're getting worse rapidly in front of you, synchronized cardioversion, one of the most important and fast-acting ways to try and correct these problems. Regardless, you need to have someone who's certified in ACLS to be directing these actions. Don't do anything like this unless you have your ACLS. And even then, try and get someone with more experience to come in. Ultimately, what's going to trigger all this? Well, it's going to be your... So a reentrant rhythm is going to be one of those. So maybe they already had a tachycardia of some kind and it just got out of hand. Drugs, your digitoxicity, get a level on those. Maybe their ectopic rhythm, again, just got worse. Ultimately, the problems that come with SVT are what happens if it goes on for too long. And so that's things like heart failure because your heart's working at a very, very fast rate without slowing down. If you got any kind of coronary problems already, that's just going to make that worse. And ultimately, it could lead to shock where you get fluid backed up in the lungs, so now you don't have enough oxygen, and so your heart and your lungs kind of crap out, and then you're in for a whole world of hurt. So this is why we take SVT very seriously, and we try and treat it as quickly as we can. As promised earlier, this is a graphical representation of how SVT encompasses so many different other rhythms. So you have SVT here at the top, and you'll note that it starts at 100. Technically, it can. And it goes all the way up to 250, which is the higher end of what the heart's even capable of. And in between, you have a lot of overlap. So sinus tach usually tops out around 160. Whereas you have atrial tachycardia, which can get way out here in the 240s. I'll actually do a star here. AFib usually likes to stop in the 170s. A flutter may go all the way up to 200s. Junctional tach maybe around 180. And so as long as you can see the P waves, you can tell all of these apart. However, if they're going so fast that you cannot see a P wave in any way, shape, or form, all of a sudden you're stuck with SVT. And so the real challenge winds up being in this range of 120 to 160s, and even a little higher, where you've got so many items that overlap. All of these different rhythms are up for grabs in terms of determining which ones are which. So do your best, come up with the best answer you can for SVT, but keep in mind that these are those ranges that they all overlap with one another, and why the P waves are so important. Supraventricular tachycardia is caused by rapidly firing cells within which parts of the heart? Well, just remember the name, supraventricular. So it's happening above the ventricles. So at that point, ventricles is out, which really just leaves you with the three remaining answers. The AV junction can be a source, the sinus node can be a source, and even cells within the atria can be a source. So it's really these last three items are the ones that can cause SVT. The telemetry tech notifies you that your patient has been in sinus tachycardia with rates in the 110s, but is now in supraventricular tachycardia with rates in the 150s and 160s. Which first action would be most appropriate? Well, you have to ask yourself, is this emergent or non-emergent? We've got a high heart rate, but you really don't know much more than that. SVT is never good because it's fast, so you're always worried about decreased cardiac output with those patients, so you need to get them evaluated in a hurry. So right away, I'm not going to delegate a CNA to check on that patient. A nurse needs to go to be the first one to look. Am I going to call the attending first and have them look at the patient for me? No, I really wouldn't do that because that's going to delay someone laying eyes on the patient. So notifying the attending first isn't the way you want to go. At that point, you now have a choice. Do you call an RRT and have the ICU nurse look at the patient, or do you look at the patient first, then call an RRT if the patient's symptomatic? That's the route you need to go. Any kind of delays in checking out this patient are delays. So if you get notified your patient has gone into SVT, it's your priority to get in there and take a look at them as soon as possible, and then you can call for more help if the need arises. So best first action, primary nurse evaluates the patient, calls if symptomatic. When providing care to patients in supraventricular tachycardia, SVT, which of the following are priorities for your care? Just look at this list and it's what you would do for any patient, right? If your patient's in SVT, you need to visualize them. You have to go lay eyes. While you're there, you definitely need to check a pulse, collect those vital signs. If there's no pulse, what are you going to do? You're going to initiate CPR. However, you need to confirm if they're DNR, DNI status before you go off and do that kind of stuff. Obviously, if there's no way of knowing, err on the side of a good Samaritan and start intervening accordingly. But if you're able to check for a purple wristband or know what their wishes are, follow them. Are you going to ambulate a patient to the restroom who's in SVT, especially if it's new onset? Absolutely not. There's no ambulation. Keep them in bed. Check level of consciousness, of course, but that's again part of your visualization of the patient. It's part of talking to them and working with them. Now, if your patient is on the floor, are you going to move them to the bed immediately? The answer is no. You're actually going to take care of the patient right where they're at, make sure there's enough help in the room, then maybe you can move them if it's appropriate at that time. But if they've fallen to the floor, just keep the scene safe. So of this list, I would say it's the ambulate and the move the patient, that those are not your priorities. Tachycardic rhythms are classified as supraventricular tachycardia, SVT, when, which of the following? Technically, any tachycardic rhythms can be classified as SVT. That's absolutely not true. Take that off the list. When a more specific rhythm cannot be identified due to the rapid rate, but still has a normal QRS width. That's actually very appropriate. You can identify P waves because of the rapid rate, but the QRS is normal. Calling it SVT is appropriate in those cases. When a P wave is not identified due to the rapid rate. I just said it, so there you go. As a first choice, because it is a non-specific interpretation, so I won't ever be wrong. That's a terrible response. Hopefully you didn't think that. So yes, the second and third items there are what helps us classify rhythms as SVT.